Good afternoon, and welcome to HIT Policy Update, a webinar and tweet chat from Health Systems CIO, sponsored by Rhapsody. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We're also going to be using the Q&A panel today. You can use that to submit your questions as they occur to you. Leave the default set to all panelists, and we'll take those later in the program. And you can also download the deck by using the URL on your screen, and it's at the bottom of our slides, and it's been sent out in the chat box. Just so you see how we're going to spend our time today, we're going to go about 30 minutes or so with our main presentation featuring Dr. John Halamka, Executive Director of the Health Technology Exploration Center at Beth Israel Lahey Health. And then we'll talk a little bit about our sponsor, Rhapsody, and then we will do our Q&A. So without any further delay, I'm going to turn it over to our good friend, Dr. John Halamka. Dr. Halamka, thanks for joining us.
Well, Anthony, always enjoy doing these because it keeps me on my toes. It forces me to read federal regulations, all the comments, and keep aware as to what everyone in industry, academia, and government is thinking. In your introduction today, you highlighted that I have a new role, and just briefly on that is that as Beth Israel and Lahey came together to form a $7 billion, 40,000-person system, I thought that the best utility I could have in my next 30 years, because remember, I'm a vegan, so I'll live to 100, is to be a mentor and to be an educator and to provide the next generation with my experience. And so I now function as the innovation lead for that 40,000-person company. And what does that mean? It means that I get to travel the world figuring out what's next in healthcare IT, looking at all the technologies and policies that every country is struggling with as we try to digitize health. So these quarterly seminars, as you'll see in today's exemplar, yes, I'll go through what's happening in the U.S., but I also want to focus a little bit on what innovations we're seeing across the world and, what are some of the other policy issues that we're seeing in Europe, Brexit, and general data protection rules, that sort of thing. So the main focus today is going to be looking at what is going on with the Notices of Proposed Rulemaking from February 11th, 2019 from ONC and CMS and the comments that are coming in, comments from the AMA, for example, or comments that the national coordinators previous to the current national coordinator, Don Rucker, have made and why they think these NPRMs are pretty useful. So just so everyone's level set, because, Anthony, we did last quarter look at the actual NPRMs themselves, but just 2 slides just to sort of review what those say. So the idea that we're finally enumerating what API to use in these NPRMs is going to be FHIR. It's going to be the Argonaut Implementation Guides, not just any API. That's important. Slightly controversial, though I don't think it should be, is that every hospital must send an admit-discharge transfer notification to appropriate interested parties like PCPs or specialists or ACOs or care managers every time a patient is admitted, discharged, and transferred. And I think this is absolutely critical in a world of value-based purchasing, where you better understand where the patient's getting care, why they're there, if it's the right care at the right cost. So the goal, as we, I think, look at the cost of healthcare worldwide, is the patients should have timely access to the care they need with the right person in the right setting at the right cost. And very hard to do that in most societies unless you have a sense of what's the patient doing. And so that's why, good requirement. Payers, and this is also slightly controversial, as we'll talk about, have to embrace APIs and provide information about claims to the patients via an app that might want to knock on the door of a payer and get such information. As folks may know, and, I don't know if you saw the news, Anthony, but H. Ross Perot passed away today.
Mm-hmm. Yep.
And remember that one of his claims to fame with EDS Pro systems and all the rest was creating a lot of these payer claim systems. And so think about this. Ross, great guy at 89, created the largest set of mainframe COBOL-based payer applications in this country, most of which are working quite fine and are still in production. And now we're going to connect those to FHIR APIs. How many web-enabled, cloud-hosted COBOL mainframes have you seen? Not so many. So this one's a little controversial because although it's good and should be done, maybe the current time frame that is outlined of 2021 is a little aggressive given what they're starting from. So maybe that'll be deferred to 2022 or so. Claims data has to be provided to patients for Medicare Advantage, Medicaid, the children's health plans, and qualified health plans. And key, a provider directory with routing addresses for every electronic transaction. So if I want to send data to a provider across town, I know how to reach them. And this is very similar to the problem we have today with email. And that is, how do I know Anthony's email address? Oh, it's because he's emailed me before, but what if I didn't? Would I go to LinkedIn? I don't know. It's having a nationwide directory pretty important. Let's go to the next slide. And you can see, Anthony and I are having a slight, standards interoperability problem today because I'm running a Chromebook that doesn't support Java and WebEx seems to want it. So we're doing this the old-fashioned way, smoke signals. So we look at what ONC says is that ONC mandates that you can't build barriers to the use of APIs like excessive charges and connection fees and these sorts of things, because an API really has very little marginal cost to connect to it once you put the API authentication and authorization systems out there. And yeah, there should be a few exceptions. If you added some value-added services, maybe there was something that was beyond just basic data communication. It included machine learning, decision support. You might charge for that, but the basic access to data should not be charged for. And remember, Anthony, I think I told you this probably a couple of years ago when I went to the Senate Health Committee, that committee on health, education, labor, and pensions, and asked our senators what they thought interoperability was. Right. And they said it's your whole lifetime medical record exchanged with every stakeholder for every purpose in real time at no cost. And, that's a pretty lofty goal, but you'll actually see in the ONC NPRM, this is the idea of eliminating information blocking, that it should be real time, it should be low effort, it should be zero to, nearly zero cost. So those words are actually in there. And then finally, the idea that a healthcare provider should be able to overcome any restrictions that might be imposed by the EHR itself. And so sometimes, what we've seen are licensing arrangements that seem to be slightly restrictive about the flow of information, claiming such things as access to an API, as getting into the EHR's intellectual property, and all these sorts of things are eliminated. So there you go, very easy access to data without a whole lot of restrictions, technical, policy, or psychiatry, all. And then next slide, just a few more words on this CMS Proposed Rule. That, remember, there are only 3 ways to influence a doctor, and you probably remember, you pay them more, you give them a better quality of life, or public humiliation. Mm-hmm. And CMS in the proposed rule is actually suggesting public humiliation as a way to ensure that people participate into this new provider directory we're talking about, which is they'll publish a wall of shame for those who don't provide electronic addresses, so it's pretty clear who's non-compliant. And the other thing that's really interesting in the CMS proposed rule is the work on patient matching strategies. None of us believe we're going to have a national patient identifier in the next couple of years, but at least having a nationwide patient matching strategy, which might take into account demographics, unrelated data to healthcare like cars you own or property you have, or biometrics, something like that. And CMS is going to be a convener, not a creator, but a convener of private sector companies working on that problem. And they will, because remember there was a sort of donut hole in meaningful use that excluded post-acute care, behavioral health, and home community services, and CMS is going to be, again, a convener to encourage adoption of technologies in those areas. So if that's a quick review of the rules themselves, all 800 pages, what are we seeing as a response to it from the industry? So let's go to the next slide. The Health Affairs article by David Blumenthal, David Brailer, Karen DeSalvo, Robert Klodner, Farzad Mostashari, and Vindell Washington. So what they said, and I think this is a true statement, that when we did XML, the CCDA, CCD, those sorts of things, it's very easy to generate the XML and very difficult to parse it because there's so much variation. And the example that I give is that Beth Israel Deaconess, following the national standard, really did, using a vendor product, create a 900-page CCDA that we sent to a primary care physician, which included the blood pressure measurements in a 3-week ICU stay every 5 minutes. Now, it's standards-based and compliant and completely useless. So the authors of this Health Affairs article suggest that moving to APIs is a really good thing. So remember, the CCDA is a document, and there is no such thing as sending a portion of a document. You can't just request the labs or just request some certain salient summary information from an event of care. It's the whole document. Whereas APIs allow you much better and granular selection of the data that you want to receive for a particular purpose. And that's good also from a privacy control standpoint, because we could suggest HIPAA minimal need to know, here's just the data you're going to get based on your query. So they like APIs. That's good. They believe that especially because APIs will now enable third parties like entrepreneurial companies to create an app ecosystem, that you're going to see really game-changing activity in the healthcare IT industry, that you don't have to wait for the Epics or the Cerners, the Meditechs, Athenas, ECWs to create new functionality. These APIs are going to be cheap, easy, and therefore third parties can just link to the data that is necessary for a given function, and then we're going to see much more agility in the industry, so very much accelerating innovation. And they also agree that because 50% of hospital revenues in the United States come from Medicare, that using that lever of saying, look, you cannot participate in Medicare unless you are making your data available without blocking via APIs, pretty powerful tool if you can get 50% of healthcare revenue in the United States as a hammer to get the adoption of this. Because remember, having the best standards in the world doesn't really matter unless there's an urgency to use them. And either you use them because it's going to be so cool, it's going to give a better quality of workflow, or you're forced to by a government regulation, and there's nothing like the threat of losing half your income to ensure that we see adoption of these new standards. Okay, well, let's go to the next slide. And so also what you'll see in the NPRM Health Affairs article is that information blocking, which, remember, information blocking is a slightly vague term, but it basically suggests that you are asked to provide data and for some reason you don't. And that could be it's an economic hardship, or it could be that you, from your vendor, don't have the technology that's necessary, or you don't have the workflow necessary, or, there are lots of reasons why it might occur. And the intent of the NPRM is to just eliminate the ones that are completely arbitrary. Like, I don't like my competitor across town, and therefore I won't give them data. And so the national coordinators highlight that it's a very thoughtful regulation because it includes certain exceptions like economic hardship and vendor lack of technology and that sort of thing, but eliminates the excuses that are arbitrary. One of the things that they highlight, and this one I think you're going to see in this upcoming comment from the AMA article in a moment, is there is concern because the NPRM does say every app that comes knocking on your door with, as long as the patient is saying, I am this patient, I am a patient of yours, and I want my data, must be admitted. And although that sounds good, and I think, Anthony, you and I and everybody, we're all very patient-focused because we're all patients.
Mm-hmm.
But I'd ask you the following question. How many end-user license agreements have you read today?
None.
Yeah. Yeah. And so, for this particular webinar, I had to download a Cisco WebEx extension. Did I read the end-user license agreement? No, I just said download. Of course I did. I'm a busy guy. Well, imagine 330 million patients in the United States, and all of them are just getting apps for healthcare. Do you think they're reading the end-user license agreements? Do they know what is being done with the data they download to that app? Do we put the burden on the patients to figure that out? That doesn't sound so good. So what the national coordinator suggests, and I think it's very reasonable, is there should be some kind of certification process that says, should you choose to download this app, you can be reassured that it is not going to sell your data to some third party or use data against your privacy preferences or something like that. And I do think that just opening the door to all these data flows without having some kind of certification process is a privacy risk. You really do want to try to help the patients and not burden every patient with having to understand every end-user license agreement. And there still will need to be a lot of education because have you ever requested your medical record, Anthony?
Not really. I think I can see stuff in a portal, but I don't think I've ever sort of requested the record.
Yeah, so here's the challenge, right? There's been a couple of articles written not about interoperability per se, but if you go to an average medical center in America and you say, what I'd like is my CCDA, fully, XML compliant, lifetime medical record exported to me digitally, they'll look at you cross-eyed in most institutions. And in fact, most HIM departments will say, would you like it single or double-sided? Right?
Mm-hmm, right.
Their sort of mindset is when you ask for a medical record request, that somehow that means copying paper. And so there's a huge educational gap right now that HIM departments across this country should understand that medical record requests are no longer about PDF or paper copies.
Mm-hmm.
Medical record requests need to be digital formats delivered in a way that the patient wants to consume them, whether that's an app on their phone or a cloud-hosted service or whatever. And especially as we move to APIs, this whole notion of medical record request that requires you to go to the basement Monday through Friday, 9 to 5, pay 25 cents a page, has to go away. And that's a huge educational issue that we have for all of our institutions nationwide. Well, let's look at what the AMA said. So you'll see a July 2nd, 2019 article written by Andis, how do you pronounce this name? I think it's Robenznieks, and it's on the AMA website. Mm-hmm. And what it suggests is the official response of the AMA to the NPRM, and they did send letters, standard responses to the Office of the National Coordinator, is they are suggesting, which is the same thing the National Coordinator suggested, that before you open up these APIs, you need to figure out how an institution can be assured that the app that comes knocking is actually not going to do bad things with the data. Mm-hmm. And it's not so much a HIPAA issue, right? Because once you hand the patient the data, what happens to it is no longer the covered entity's liability. But it just still sounds bad that if two guys in a garage in China create an app that is sending data to some website and some patient comes knocking on your door with it and you hand off the data to that app, it just doesn't feel right. Mm-hmm. So there need to be some kind of controls. And especially with this understanding that if there's a third-party disclosure, that the patient is really opting in and consenting in a meaningful way to that third-party disclosure. An exemplar of that is my colleague John Torres, who runs the Center for Digital Psychiatry at Beth Israel Deaconess, downloaded every app for behavioral and mental health from Apple's App Store, every one of them. And then he read the end-user license agreements on every one of them. And he's published a paper on this that basically suggests that 80% of the behavioral health apps on the App Store today share your behavioral health data with some third party. 80%. That sounds bad, right? If I'm using an app to track my mood, I'm feeling sad today, or, gee, I didn't take my meds today and this or that symptom is occurring. Imagine that very private information being shared with a third party, and maybe you consent to it, but I bet you most patients don't even know what's happening. Right. So the AMA has highlighted that, and so that's good. A couple of other things in the AMA response letter. This one I don't really like so much. In 1999, when I first worked on patient portals, there was this notion of, should you share the data with the patient? They might not understand it. They could get anxious. They could get confused. Maybe we should have the doctor, in a paternalistic fashion, be a partner in sharing the data with the patient. That kind of thinking is old school, right? We shouldn't be thinking that way anymore. So when the AMA says, oh, gee, patients having fluid access to all their medical intervention, medical data could circumvent, physicians' clinical decision-making and guidance, I think that's just not appropriate in 2019, in my opinion. One of the things I guess that is an interesting concern, if there is this more fluid data flow between providers and payers and payers and payers, how do we ensure that the data isn't used to withhold care from patients? I mean, although with the ACA, of course, we have a prohibition against the use of pre-existing conditions as a restriction getting insurance, might you see certain therapies denied because a payer has a rule set that based on the EHR data they never had access to but now do, that they deny some service or care to you. And so that's a concern. Specifically mentioned in this AMA write-up is the idea of step therapy. And I don't know, Anthony, have you ever heard of step therapy?
Not that I know of, no. Exactly,
right. I'd never heard of it either, and I've been a doctor for 30 years. But here's the step therapy idea. Suppose, and I always love picking on Anthony. Let's suppose Anthony has a community-acquired pneumonia. And erythromycin is 25 cents a pill. It's dirt cheap, but it makes you feel like crap. So step therapy is, I'm going to give you a drug, which is probably effective, but it's maybe not the best drug because the best drug's expensive. So we'll try you on the cheap one, and if the cheap one fails, then we'll go to the expensive one.
After you feel like crap.
Yeah, right, or it doesn't work or whatever, right? And so you get it, right? You don't want every single person in the healthcare system to be getting what might be an unnecessarily expensive drug. But the concern that is listed in this AMA article is if your payers have comprehensive access to your entire clinical record, might they start imposing medical decision-making that normally would be left to you and your doctor and say, Anthony, we know that a Z-Pak would really work for you, azithromycin, and would be completely symptom-free, but they're expensive. So we're going to start you on erythromycin no matter what your doctor says. So I get it, right? I mean, it's probably a valid concern where some policy making needs to be done to ensure that patients and their clinicians work together to give a therapy that balances efficacy and cost. So those are sort of the general themes of what you're seeing in the NPRM comments. Lots of comments coming in, but mostly it's a good idea. We should move forward with it, but we should just make sure there are guardrails, that we aren't using this data in ways the patient never intended, whether that's third-party sales or being sent to the payers to get in between the patient and the provider's agreed upon care plans. So I suspect what's going to happen, come fall, these things are going to get approved, they're going to be finalized, and you might see such things as we talked about, the payer compliance deadlines being extended, and you presumably will see some commentary on how do we ensure that the apps are actually sort of reasonable and credible before we let them in the front door. But otherwise, I expect it to go forward largely intact. Well, let's jump to Europe for a moment, because this is a policy update, right? And we are creatures of the world. And I was in Finland 2 weeks ago at HIMSS Europe. And what you see across Europe is not only, of course, are there concerns about Brexit and the stability of the European Union, but the general data protection rules are best described as HIPAA on steroids. Right. The idea is that when you get a HIPAA fine, and you're a journalist, Anthony, you've covered HIPAA fines, or 100,000 here, 200,000 there, maybe $1 million in a really egregious case. Mm-hmm. The GDPR penalty is 4% of your worldwide revenue per breach. Right. So imagine Apple, which is a $1 trillion company, had a privacy breach. The penalty could be 4% of $1 trillion per breach. Right? So what is that doing to Europe? Europe is saying, oh my God, given the risk that in fact we would go out of business if we had a privacy breach, we better not use cloud. We better not use mobile. We better not embrace the internet because all of those things are going to potentially cause additional risk. And they've raised, at this conference in Finland, some fascinating issues, which is, let's say we want to use blockchain. Well, the issue with blockchain is there is no center to the blockchain. It depends on the blockchain, but let's say it's Bitcoin, Ethereum, these kinds of things. It's distributed across thousands of independent blockchain operators, these miners. Well, if GDPR says such things as, all the data must reside in Europe, well, how can you guarantee that every byte of data on a blockchain resides in Europe? Right? You can't. And so they're just wrestling with questions like what data can be stored for what purpose, with what granularity, where. And they'll presumably come up with some hybrid solutions where maybe you can use the cloud or blockchain for de-identified data, and certain kinds of identifiers still need to be kept on physical servers in known locations. But I just tell you this because Europe is really struggling with figuring out how to emerge from the what we'll call client-server, locally hosted, licensed app in a world now where the regulatory compliance penalties are 4% of worldwide revenue. Europe is also working on what we all think is really important, precision medicine and genomics. I can de-identify Anthony's medical record. Instead of using your birth date, I'll use your age, 29. Instead of using, your physical address, I might say, he's in the mid-Atlantic region, right? I can de-identify your data sufficiently so no one can re-identify it. Mm-hmm. How do I de-identify your genome? That's kind of impossible, right? So if we want more precision medicine, more machine learning, more technology to give the right care to the right patient based on millions of patients like them, how do we intelligently protect the genome? So Europe is thinking through some of those things and trying to de-risk it. And especially you're seeing this in Norway, Finland, Sweden, Iceland. A lot of the Nordic countries and Iceland are real leaders when it comes to thinking of population health and aggregate data sharing. So there you go. That's a bit about HIMSS Europe. And now I just wanted to cover a little bit of innovation. As I travel the world, I'll be in London next week, then Amsterdam, then Jerusalem, then Shanghai. What kinds of things I'm seeing? Mm-hmm. Across the world, you are seeing this migration to Argonaut Fire APIs for getting data, for doing decision support workflow, scheduling workflow, and eventually, maybe a year or two away, but eventually write back of data into the electronic health record. Write back is hard, right, because of referential integrity, right? If you are trying to write back into Epic or Cerner, I mean, there are thousands of rules of how data has to be cleansed before they, actually write it into a data structure. So it is harder. But you're still seeing this movement very much that HL7v2 for ADT still used, CCDA for certain kinds of purposes still used, but APIs really being embraced pretty rapidly. You're seeing machine learning being used in novel ways to enhance workflow, predict what patients will need what care when, what signs and symptoms equate to what diagnoses and care plans. Seeing lots and lots of third-party companies come up with those kinds of things that are going to leverage the kind of things that the NPRMs include, these APIs, to offer more value-added services to patients and families. You're seeing more and more of a push for home care, telemedicine, and telehealth. And especially those of you with young kids, how exciting was your pediatrician office visit where you had to take a half day off work and sit in a waiting room with kids coughing on your kid? Not great, right? Wouldn't it be better if, like in Israel, you see this company, TytoCare, don't have any stock, don't worry, no conflict of interest here, that says, I'm going to give parents a kit, and that kit is going to include a 4K HDR high-resolution camera, put it over the ear, nose, and throat, and then in 5 minutes, a pediatrician will review the images and decide antibiotics or no. You did this in your kitchen for $25. No one had to lose any work time. That's nice.
I like that.
And you're seeing more and more of a push to that kind of thing for two reasons. One, it reduces the total cost of care. But two, across the world, we have aging societies, not enough clinicians to serve the aging societies. We have to rethink how we're delivering care so that everyone can practice at the top of their license. Seeing more and more use of Internet of Things, more and more devices that can measure body telemetry being introduced. The idea that I don't have to go to a sleep center for a sleep study. I just buy a $100 device and put it under my mattress, and it does my sleep study for me. Or my watch measures my variation in heart rate, my blood pressure cuff, my glucometer, my thermometer. All this data is gathered about me, seeing this worldwide. But there are still big questions of what do we do with all this novel data? Where is it stored? Who's accountable for interpreting it? What if they don't see it? So all of our various societies are working on that question right now of medical liability and accountability around novel sources of data, because clinicians are already overwhelmed. Giving them more responsibility isn't going to be exactly better for their mental health. And, of course, across the world, more and more comments about security. And every day, I'm sure you've covered this in Health Systems CIO, you've read about all the various municipalities getting ransomware.
Right.
We're gathering more digital data on more patients for more purposes, that we're shipping more and more places with more APIs. Oh, what are we going to do to ensure the integrity of that data and that its privacy is respected, and what tools and regulations do we need to be put in place? Because HIPAA, 1996 creation, it doesn't really cover the modern era as well as it should. So there you go, Anthony. There is our quarterly what's going on in Washington, what's going on in the world, what's happening with innovation. And I look forward to our new quarters as we talk about what I am seeing in my travels and how we can make healthcare a better place. But happy to take questions.
Love it. Very good. All right. So please type your questions in the Q&A box. Leave the default set to all panels, and we'll look at those in a moment. But first, we are going to thank our sponsor, Rhapsody, and we're going to learn a little bit about them. So I'll give you an overview of Rhapsody, and you can go over and check them out and thank them for supporting us. So Rhapsody is a healthcare IT company that develops interoperability solutions used by healthcare providers and vendors around the globe. Their foundation product, Rhapsody On-Premises, connects healthcare systems by enabling seamless data integration, which helps clinicians and other users to access the right information right when it's needed. Knowing that every healthcare provider is unique with its own challenges, the organization also partners with their users to co-develop solutions for those unique interoperability challenges which out-of-the-box solutions often fail to address. Daily, their Rhapsody platform processes over 1 billion messages for their 500-plus customers and partners worldwide, both on-premises and in the cloud. The platform is proven high-performing and comprehensive with built-in FHIR capabilities for robust and reliable acquisition and exchange of health data. To learn more about Rhapsody, visit rhapsody.health. So once again, we want to thank the folks at Rhapsody for supporting this event and making it possible for you to absorb all this great information. So let's go to our first question. Based on today's rules, we must provide all results to patients as soon as they are available on the portal without provider intervention. Oh, that's a question. Can, quote-unquote, sensitive tests be held back for a period of time to allow for provider-to-patient connection? So, Dr. Halamka, must they provide all results to patients as soon as they are available on the portal without provider intervention?
So what a brilliant question. And so what you'll see in the NPRM is there are 7 exceptions to the information blocking provision, and one of them is the potential restriction of data flows and the protection of patient safety and privacy. And so let me give you sort of 2 examples which would illustrate what I think are probably appropriate, what I'll call not blocking, but process. So imagine, and I've probably used this example before, that Beth Lahey is largely focused on adults, but Children's Hospital across the street is focused on people under the age of 18. I forgot, Anthony, do you have kids?
I do. I have 2 boys, 8 and 10.
Okay, so you haven't run into the problem yet. So imagine that you have a child under the age of 12. Should they have their own portal? Probably not. Should a person, let's just imagine your child is seeking sexually transmitted disease or contraceptive treatment at the age of 15, should you be sent that data immediately? Should it be sent to the patient, not you? Well, let's imagine it's something different. It's a flu diagnosis. Oh, well, of course that, right? So this thoughtfulness about, especially when you're dealing with people who are between the ages, say, 13 and 18, of who gets what when, what parents get what when, would be a perfect example of where this exception to the rule might be used in a pretty thoughtful way, right? Mm-hmm. And I would be, as Children's Hospital has decided, that if you're under 13, your parents, in effect, get a log on to your portal. If you're between, 13 and 15, certain information is shared with your parents, other information is shared with you, and if you're above 15, it's all just you. That's a policy that Children's made, but a perfect example of how the NPRM allows that kind of policy. Another example, and this one is touchy, really touchy. Because remember, my wife was a cancer patient. She's doing fine. Yeah. And she was really angry that there was information blocking on her cancer diagnosis over the weekend. Right? That is, she knew that because we had put this in place years ago, that if you had a pathology or cytology test, that test would be reported to you in person by a clinician. Mm-hmm. And so here's the interesting issue, which is, let's imagine, Anthony, I'll pick on you again.
Sure.
You had a cancer concern. You had a test done on a Friday. Would you want to spend the weekend worrying about whether it was positive or negative, or just no?
No.
And so that's the challenge, right? Is that some people would just say, I just want to know. And others say, well, God, that's a pretty emotional thing. I'd want a person to talk to me about it first. So the NPRM allows that subtlety, and I would guess that as time goes by, we're going to be sharing more and more data, even sensitive data, with patients in real time without restriction. But we're probably going to go through a tweener period
Yeah.
where a patient might say, God, if I have cancer, I really want the benefit of a conversation with a human and not just to read it on a website. So it's fine. We have the latitude to do that.
No, that makes a lot of sense. So I changed my answer. First I said I want to know, and the more I thought about it, I don't want to know until I'm sitting down with my doctor. So.
Right, because if I told you you had stage 4X cancer, well, stage 4X cancer could be a death sentence or not.
Right. Right.
And it depends on the cancer.
Yeah. No, it's good point. Good point. Next question. Any comments about progress in open source EMRs?
Yeah, so the interesting open source EMRs like OpenEMRS, they're especially outside the United States, where you're looking like sub-Saharan Africa or India, where I do a fair amount of work, no one's going to be able to afford. Even the cloud-hosted offerings that are of a somewhat reduced cost, and there's really a sense that open source EHRs are going to be really efficacious in places like South Africa or Mozambique or Senegal. So yes, I'm seeing a lot of OpenMRS or things like Vista derivatives being used outside the United States, but I'm really not seeing a lot of traction inside the United States. And I think a lot of that has to do with, given the difficulty of certification, that there just seems to be a lot of compliance and regulatory concern about buying something that is open source, that you potentially could run into regulatory or compliance penalties because it doesn't cover every single government requirement. So I'm a big open source person, love the idea, would certainly like to see open source used in more settings, but in the U.S. at least it's still limited.
Very good. Next question. I joined a few minutes late. Sorry. Is there any update on some of the key disruptors in healthcare like Haven?
Well, wouldn't that be a fascinating question? So how much do you know about Haven?
Not much.
Okay, so they're 50 feet from where I'm standing. And I don't know anything about them either. So I'm at Beth Israel Deaconess, which is on Brookline Avenue. And Haven, Atul Gawande's shop, is on the 8th floor of the Landmark building on Brookline Avenue. And so how about this? Why don't I totally speculate with absolutely no inside knowledge? So if you look at who Haven has hired, Dana Safran, for example, is their chief analytics officer. She was the chief data officer of Blue Cross of Mass. Their hires seem to be people who are big data analytics people who probably have enough wisdom to understand care plans, variation in care quality and cost. And so here would be my guess. Although Atul has not said one thing about what Haven will produce, what if they are able, through the use of IT, to create a more efficacious, higher quality, lower cost plan of care, like Oscar is also trying to do with Care Navigators, and there are a number of companies, Iora Health, these kinds of things. Might that be attractive to ABC? And by ABC, of course, I mean Amazon, Berkshire, Chase, because those are the three sponsors of Haven, because they're spending, as billions and billions on employee healthcare costs, and through the use of analytics and customer relationship management and appropriately incentives, can they start to bend that cost curve? That's my bet as to the products and services they're working on, but it's pure speculation.
Just from you looking with the binoculars at the building.
Exactly. That's it. 8th floor, Landmark Center.
Got it. All right, next question. Do we need an independent entity to assure therapy quality, purity, etc. for all therapeutics like we do for regular drugs? For example, the apps you mentioned that Dr. Torres studied, or other complex meds like biologics?
Well, so the FDA is taking a great interest in this. Right, and so the FDA would absolutely, in its risk-based assessment, tell you that an app that is more or less lifestyle, wellness, administrative, low risk, it's okay. But an app that is going to provide diagnosis or treatment needs a pre-cert. I mean, you need to actually submit the details on the app or the device to the FDA so they can do a risk assessment and decide if it's a high risk, then it is actually going to need to go through some sort of 510K type process. So I think the answer is the FDA is really thinking hard about this, and they're actually on a pretty good trajectory.
All right, next question. Most of the APIs we've been looking at, even from reputable companies like Microsoft, although often free of charge, come with agreements that you must sign allowing the company to share access information with unnamed third parties. Any insight on pressure being applied for popular app stores?
Yeah, did you see Steve Wozniak's comments this morning in the New York Times?
I did not.
So Steve Wozniak was cornered in the Washington Reagan Airport by that highly credible journalistic organization, TMZ. Yeah. and yeah, I think we had the appropriate response. Oh, God. Anyway, and he was asked about Facebook, and he basically said all humans should get off Facebook because there's no way we can actually control data flows or privacy through that platform ever. So just get off. So I tell you that anecdote because I think what you're starting to see is a backlash, right? There's a backlash that the big tech providers that are in effect making their money by selling your data are going to need more stringent regulation. So in a direct answer to the question, just as the NPRM says no more information blocking, no more API charging, I'm betting we're going to see regulation and legislation that is going to say no more monetization of data without very express consent. So such generalized provisions in agreements are going to have to be struck.
Very good. Can you speak to the quality of the data shared via APIs? What if the data being shared is incorrect, and what will the consequences be for consumers?
Wow, and that's a really good question. So one of the issues that we have is not so much the data, but the metadata, which is for this piece of data, who entered it, in what workflow, for what purpose, right? So I think there's probably, here's the example I give when I lecture, which, Anthony, I'm sure you've heard before. My mom, 5 years ago, saw I had a red dot on my stomach after getting ampicillin and declared me penallergic. So think of the metadata. Mom, in 1964, saw a red dot on your stomach. As opposed to a nurse last week gave me penicillin, I nearly anaphylaxed and died, right? The metadata would be a little different. So I think the question really raises the point, which is that as we do, the API data is, got integrity, but we need to ensure that we understand something about the provenance of some of this data before we use it for novel purposes. And certainly a lot of the data that we gather in EHRs today was potentially not designed for machine learning analytics or some such other purpose and may not have the integrity or quality that we need. So in the moment, every healthcare institution is responsible for the accuracy of its own data. So, they're the accountable party. But I would be very wary about incorporating novel sources of data like such things as Internet of Things data directly into the legal record until you understand a bit more about where it came from and what purpose it really is useful for.
Very good. Next question. As an EHR vendor, are we better off building our own patient-facing app or integrating with Apple, iHealth, or some other app? Would both satisfy the new regs?
Yeah, and I think the answer is both, right, which is that Beth Israel Deaconess has always had a patient portal, right, part of meaningful use certification, but it also has embraced HealthKit. We created an app called BIDMC at Home that sits on top of HealthKit and then provides unique insights, alerts, reminders to patients from the data that's in their HealthKit repository. So ideally, create a portal. I mean, that's sort of a floor, but also make the API available for novel third-party apps that may do more than your portal will ever do. I think that's the app ecosystem to come.
All right. Last question. This one is from me. I was at Chime had an advocacy summit a few weeks ago in D.C. that I went down to. And a lot of the comments and questions for the different panelists who were mostly with government, with regulators and all this kind of thing, were about the silos that the different departments in government have, and they're each, requiring things of people in healthcare, but they're not seeing the cumulative effect of all the departments are requiring on the healthcare providers, and that it's a lot. And they said, we're trying to do a better job of coordinating and streamlining and harmonizing and all that. So what are your thoughts around that? Are you seeing progress?
Yeah, so Don Rucker is very sensitive to this issue. And, during the Obama administration, where I was running the Health Information Technology Standards Committee, what you saw is we introduced meaningful use, ICD-10, ACA, and the HIPAA Omnibus Rule simultaneously.
Good times.
Right? Right. And that was completely nuts. Right? And each of them was a very valuable contribution to the ecosystem. But the amount of change required, is it any wonder that clinician burden is high and everyone wants to quit, right? Mm-hmm. And so Don really believes that, again, we were all well-intended, but one has to take a look at the entire burden created and scale back some of the things like the data entry requirements and the quality measures for now, because the cumulative effect is too high. So, yeah. This is the ONC is really the gatekeeper working on that issue.
Very good. Wow. Another excellent session with lots of great information. Very enjoyable as well. So, regarding continuing education, those of you with the Chime CHCIO certification get 1 CEU for attending our events. So let Chime know you were here. And if you've asked us to do so, we certainly will. If you need a certificate of attendance for a different CEU program, you can use the final slide in this deck. You will receive an email when the on-demand recording of this event is ready. If you want to sponsor one of our upcoming events or book a custom event, you can reach out to Nancy Wilcox from our team, and you can go to our site to register for our upcoming webinars. So with that, I want to thank our good friend, Dr. John Halamka. I want to thank Rhapsody very much for sponsoring this event today, and I want to thank you for attending. With that, everybody have a wonderful day. Thank you.
And thank you.